Retinopathy of prematurity affects children who are born young and born light. When I talk to parents in the NICU, what I explain to them is that why are we examining your child, right? And we're examining your child because we want to make sure that the retina, which is the back of the eye, is developing appropriately. And we examine every child who's less than or equal to 30 weeks gestational age, and we examine every child who's less than or equal to 1,500 grams. And of course, any child that the neonatologist wants us to examine to make sure that the overall eye health is developing okay. So in terms of retinopathy prematurity, what happens is that the blood vessels in the back of the eye, they may not be fully developed when your child is born. And what will happen is that when you're in utero, you're in a condition where there's decreased oxygen. And then when you're born early, all of a sudden you have a lot of oxygen exposure, okay, that you normally wouldn't have. So what happens then is that the blood vessels can then stop, the regular blood vessels, and then what we worry about is the formation of new vessels that can form. And these vessels can potentially cause retinal detachments and other issues that can potentially make a child go blind. So what is ROP? ROP is a condition that affects the developing retina, and we'll go into the different stages and zones and the categories of disease. The terms that we use, and you'll see this, and many parents will already know this when I talk to them, are zone, stage, and the presence or absence of something called plus disease. There are also different categories, such as type 1 or type 2, mild, and you'll see these things as we discuss ROP. So when we talk about zones, the way that I describe this to families is that this is the extent to which the normal blood vessels have developed. And we have zone 1, we have zone 2, we have zone 3. And I equate it to, zone 1 is very immature, zone 2 is more mature, but not quite there yet. And zone 3 is pretty close to being fully developed. There's also stage, right? We categorize stage as stage 1, stage 2, stage 3. Stage 4 is divided into 4A and 4B, and stage 5 is now subcategorized according to new definitions. The way that I describe it is that stage 1 is you start to see that demarcation line, right? So that change where you have the normal developed retina and then the retina that's not developed, or we call it avascular. Stage 2 is when you start to see a little bit of elevation or more substance to that line. Stage 3 is when you start to see new vessels that have formed that we call extraretinal new vessels. And then this starts to alert us to maybe we have to start seeing your baby more often. Stage 4, A and 4B, just generally speaking, are when the retina starts to elevate, so a retinal detachment. 4A does not involve the very central vision, and 4B does. Stage 5, I think holistically, is when you have a total separation of the retina, and these are very complicated cases. We don't see that often in the United States, but we do see it occasionally. And then there's something called plus disease. So plus disease is an indication for treatment. And there's also zone 1, stage 3 without plus, where you're going to need treatment as well. I also want to mention that you'll hear the expression type 1 ROP, which is treatment requiring ROP. And you'll also hear categories such as type 2 ROP, which basically, for those of us who do exams, means that you'll have to see the patient more frequently, usually within a week. Nowadays, we have a number of treatments that we can provide children who have treatment-requiring disease. Historically, we've used laser, and the laser treatment will be directed towards the retina that hasn't developed, so the avascular retina. We also have treatments such as injections of medicine. There is now an FDA-approved medicine for ROP, which is called aflibercept. And there are other drugs such as ranibizumab or also bevacizumab, which have been used. So there are multiple treatment modalities, specifically injections of these anti-vascular endothelial growth factor agents or laser. I think the most important thing that parents can do after the ROP diagnosis is just to make sure that your baby is being examined and screened. It's a team effort. The parents are very much part of the team. And I think the most important thing is to make sure that we're communicating with each other and that we're making sure that your baby's examined, because each exam will determine when the next exam is. And if treatment is required, we want to do so in a timely fashion. The most common questions that we hear from parents is regarding how is this going to affect the vision and the overall livelihood of my child. And I think that what we have to keep in mind is that blindness from ROP, so if a baby has ROP, blindness from this condition is almost always preventable. And it's preventable because we have good screening protocols. It's preventable because we have this team approach. It's preventable because we have good treatments. And I think that if we catch it early and if we treat treatment requiring ROP in a timely fashion, we can prevent blindness. Also, very importantly, as we discuss this, it's not uncommon to have ROP if you are born prematurely. So one thing to keep in mind is that of the children that we screen, about 70% develop some degree of it. Okay, but we have to keep in mind that over 90% of the time, it resolves on its own with no major issues. Regarding anti-VEGF agents, I think it's important to understand yes, I agree. There is still much that we may not know in the long term. We've been doing this for over 17 years. There are a number of clinical trials that have been underway and that continue. One of them is Firefly, which is an international study. And there's now data from that study, and it's Firefly Next, which just reported 2-year outcomes regarding safety and efficacy for that group. And I think it's incredibly important. There is very clearly a subset of patients who will benefit from anti-VEGF therapy. And we're fortunate to have these therapeutics at our disposal for the care of these children. But one thing I always tell parents when we have this conversation is, are you comfortable with us using these medications, given that we don't know certain things? Are you comfortable with the unknown? But at the end of the day, these medications are very effective in promoting regression of the disease and ensuring or helping prevent blindness. I think it's also very important to emphasize for the ophthalmologists and also for all the healthcare providers on the team to recognize that the families are going through a lot, to recognize that there are so many other things happening in the journey of their child that we are focused on, yes, the ophthalmology condition or the eye condition and the eye health, but it's important for us to listen, to empathize, to communicate, and to make sure that whatever we're doing, we're making sure that they recognize that we are all part of the same team to care for their child.
So the exam, diagnosis, and possibility of treatment are really linked together based on the preparation for parents. I would say it takes some time to review the information you're given by the provider, either from the NICU or ophthalmology team, whether there are actual materials are given or resources online. Take some time to review that, because I know there is a lot of information on that and you might have questions. So ask those questions and feel empowered if you don't understand something. And even though they've answered questions, continue to ask those questions until you feel confident or you feel informed. So in the NICU, there's a multidisciplinary team, and it depends from NICU to NICU. You'll hear different titles, but of course, the NICU providers or the care team for your baby, the bedsiders, the ophthalmology team, or what we call here the ROP providers. And if there's a coordinator that's dedicated for ROP babies, you'll meet someone like me. Otherwise, there are clinical coordinators, case workers that will be aware of the diagnosis of ROP and will help track those exams and those babies. But honestly, I always say welcome to the team, to the parents, because then you'll be part of our team as well. So different NICUs will have either printed materials ready for you, online resources. The ophthalmology providers or ROP providers, coordinators will have education materials for you. There's a lot of information out there, just like any other health condition, but we want to be careful where we look as well. So that you are aware the information you're being given has been reviewed by a team, not just the ophthalmology team, but the NICU providers. We want to make sure from even the nursing standpoint, we're very dedicated to making sure it's the best evidence-based practice out there and you're receiving the most up-to-date information. So families can be best prepared during that transition of discharge into home or to outpatient clinic by making sure that you've had your questions answered. You've made a list, because I know you've received a lot of information throughout the stay there, and you have many other appointments possibly. So making sure you do have the information about where to go for your outpatient appointment, who to contact, the results of the last eye exam. And also things that would help would be to reach out to the ophthalmology team directly and see if they recommend anything else. If you are deciding to go with another team, the NICU will provide resources to help with that transition of care. It's very important to keep track and monitor these eye exams. Because every baby could be different and developing of ROP, we want to be careful with not having that appointment for outpatient and having that contact information. Here at Lurie, what has been successful is our program consists of a team of us ophthalmology, including myself, but also we do keep close contact with the NICU. Child Life is also involved. Administrative assistants are dedicated for the ROP baby appointments as well, and NICU management. So it's a multidisciplinary team effort, and my support specifically is to help facilitate those appointments, that communication between transition of care, and provide the parents with information regarding what to expect, how long the appointments are, what to bring, even where to park, things like that. Resources are available here with social work also involved if there's a need for parking, things like that. Another thing we also take care of is to address the emotional part of it, especially if babies have been treated. We want to make sure we support the parents or family with that.
I remember the first time hearing the words ROP and knowing that it may be coming. We were receiving weekly exams up until that point, but the day of the actual diagnosis, we were flooded with overwhelm. I remember feeling so many emotions, mainly about what would his future hold. But as a mom of a micro preemie, I knew that the treatment would also probably mean setback in our journey. And so there were so many emotions that started to go through our mind. And one of the things I remember asking the doctor often was, what does the future look like? What does this mean? And I remember the overwhelm of information, but not knowing what to take in versus what to protect myself as a parent. That would cause more overwhelm of what we might be facing after this diagnosis. As a parent of a child with ROP, to remember that we are part of the team. We are a critical part of the team, and you are the expert on your child. Don't diminish your worth as a parent in that collaboration as a team member. You really are your child's best advocate, and follow your gut. We all know that parent gut, and I found that that really was priceless as I navigated this journey. So follow the instincts, ask questions, know it's okay to feel uncertainty, to feel the emotions that come with the diagnosis and treatment and the future treatment that may be needed, but really utilize the resources and the community available. There's going to be support for you along your journey. And as parents, it's really up to us if we utilize that support. I think we were overwhelmed at the thought of our son was born at 23 weeks, and we were about 2 months into our journey. He had already had one surgery, and with the diagnosis, we were told within 4 days he would have the laser treatment. And we knew what that meant for his medical journey, to be placed back on a ventilator, and what that might provide for him. That was the overwhelming part right then and there, to see him be set back. I also remember feeling very overwhelmed. I remember the exams like they were yesterday. I remember how hard it was to see him be examined, how hard it was to see him be rolled back to surgery, to come out from surgery like that picture was yesterday. And also knowing we were told, the treatment, we might not know for a few weeks if it was successful. And so the thought of having to go through that again was overwhelming. It was also very difficult for us because having a micro preemie, we had already had a lot of things be told to us of we don't know what his future holds. We don't know what this diagnosis will mean for him. And for us, it was another piece that hope was taken away from our journey. And to not know, what his future might hold as far as vision and what his needs would be. And then post coming home, we are a rural family, so the closest ROP doctor from us is over an hour away. And I remember those visits being long and difficult. And he also had a lot of other medical needs. So the visits were long as well. Our son, Cooper, is a thriving, successful 11-and-a-half-year-old boy. In addition to his ROP, he did receive an additional diagnosis of CVI, which has added some complications to his vision. He continues to use tools. We've built a team around him to support him in his education. We go to a very small school district. He actually has 12 kids in his class, and he's been able to continue to be successful because of his determination and grit. Are advocating for him and his amazing team that helps him be successful.
Being able to see certain things far away and things are blurry, and learning what I need to in school to help me see better. I'm in 6th grade and I have a TVI to help me, and I use a magnifier and enlarge books, and my teachers enlarge print if needed. Don't be afraid to ask for help, and never give up even when it's hard, and good things will come. Being able to drive the tractor and grain cart for my dad during corn harvest, and my test scores in school. My favorite things at school are science and history, and I recently got to go on a trip to DC with my school teacher and friends.
What I remember is that Jordan was born at 26 weeks gestation age, and he was in the NICU for approximately about two and a half months. And prior to him being able to leave the NICU, the doctor came and did the vision screening on him and informed me that he saw something possibly going on with his vision. And he told me that I had to go take him to a specialist after I got him out of the hospital. And so I was feeling extremely overwhelmed after having Jordan is my second child, and not knowing what the diagnosis was going to be, and then was able to get an appointment with a doctor, and it was informed that Jordan was being diagnosed with ROP stage 3. And so I began to ask a lot of questions about what that meant and what that is and what other things I needed to do. And then needed to proceed to going on to a ROP specialist. I would say the most challenging part was the unknown. Was Jordan going to have a vision impairment that will require an extensive amount of services and supports? Would he need glasses in the future? But one of the things that really helped me was him being able to receive early intervention vision services, which was really, really helpful in speaking to a vision teacher and being at the therapy sessions, asking a lot of questions, having to the other part that was a lot for me is I would have to take him to see the ROP specialist often. And that was a lot. It was very overwhelming seeing my little baby having a device put into his eye so they can examine him. That was frightening and overwhelming. But going to the doctor and the vision services, it really helped to solidify possibly what his future could be as far as his vision. What I would say is that we definitely have to be advocates for our children and ask a lot of questions, which is something I still do to this day, because when you ask questions, you learn, and you learn a lot about your child's condition. I learned a lot about Jordan's ROP, and many times when I would speak to parents, they would ask me, was I a nurse? And I was like, no, I just asked a lot of questions to understand what was going on with his vision and what the possible future could be around his vision. And so that was really helpful. And just, being your child's advocate is the biggest thing that you can do, and ask a lot of questions. It's okay to ask questions of the professionals and they need information from you in order to figure out how to treat your child.
My ROP also has affected my eyes since I was diagnosed as a baby, and still has some effects today. When I'm outside, my eyes still are sensitive to sunlight. ROP challenge in my life when I was in school. I began having issues when sensitive to seeing the blackboard and headache. My mom took me to the eye doctor, and I have a mild vision impairment. I wear glasses that help me see better at my job on the computer and when watching TV. Wear my glasses, I help my advocate me be able to see better, to have success for adult life.
We have parent centers in all 50 states, including some territories, which also includes Puerto Rico. At the parent centers, which is funded by the Federal Office for Special Education, we all provide education support by the way of trainings on various topics around the special education processes, healthcare processes, parent support processes. And then we also provide a lot of education and support nationally to other organizations and partner with a lot of our state and national organizations to ensure that families and professionals are working together to ensure appropriate services and supports for children in the education and healthcare systems.
Different parents need different things when they're in the NICU, but I think most parents would say it's helpful to have at least one designated person on the team whose responsibility is the well-being of the parent. Somebody who's checking in with them and asking how are they managing the stress and the trauma of what they're going through. And sometimes that might be a psychologist, it might be a social worker, it might be a parent on staff, but somebody who's able to listen to the parent and really hear and understand all that they're going through with their family, someone who can validate their emotions and the difficulty of what they're going through, and then also empower them to take care of themselves, because we know that oftentimes, that kind of goes by the wayside when your child is in the NICU, but also empower them to advocate for their baby, to be the voice for their child. And if there's something that's happening that they aren't sure about or aren't clear about or are uncertain about or disagree with, knowing that it's okay for them to question that, for them to speak up, to ask for second opinions, and that sort of thing. Some of the biggest challenges that families experience in the NICU is grief and guilt. Guilt is one of the biggest emotions that parents experience, even when they're aware that they are not the cause of their baby being in the NICU. So working with them on how to release that guilt. And then grief. Parents don't plan to be in the NICU. And when they imagine having a baby, they have an idea of what that looks like, and it does not match up with their experiences. And so helping them to really grieve the dream and really be present in the reality. Some of the major issues that I address with families as a psychologist are depression, anxiety, and post-traumatic stress symptoms. Again, families are dealing oftentimes with their worst nightmare by being in the NICU. And so creating a safe space where they can express their emotions and really work through some of those mental health concerns that are really normal for parents who have a baby in the NICU. One of the things I would encourage clinicians working with NICU families to think about is how to engage their empathy. Parents are struggling when their babies are in the NICU, and they aren't always able to show up as their best self. And so really engaging that trauma-informed perspective to think about what else might be going on for this parent, even outside of the fact that their baby is in the NICU, and giving them as much grace as you can.
Hand to Hold is a national nonprofit organization. We provide early intervention mental health support for NICU and bereaved families to help parents process the trauma that they experience when it is an early birth or a baby born with a medical condition and needing a NICU stay. Hand to Hold offers a variety of support for NICU families, from one-on-one support from our peer mentors to an app and a podcast and educational materials. We really want to meet families where they are throughout their NICU journey and invite them to participate in our virtual support groups when they're ready, or connect directly with a peer mentor to provide ongoing support throughout their NICU stay. NICU families can find support from Hand to Hold just by going to our website. It is handtohold.org. They can also find our podcast in their app for podcasts, as well as our NICU parent app in their app store. So they can connect directly to our family support specialist within the app, but also connect with other NICU families from across the country who have a variety of different NICU-related experiences, including ROP. As a NICU graduate parent, it's really important for me to communicate to clinicians just how important early intervention support is from a peer mentor and from family support specialists and psychologists, for families to be screened for perinatal mood disorders, to be given resources to connect with support groups and peer mentorship. It plays a vital role in helping parents adjust to the NICU, helping them bond with their baby, and preparing them to be strong advocates for their baby after they are discharged from the NICU. As any parent who has received an ROP diagnosis, they know just how stressful it is watching their baby be screened and going into surgery, and the repeated visits to the ophthalmologist for follow-up care. So having the support of a peer mentor throughout the NICU stay and after NICU discharge is just extremely important. So we invite anyone who's had an ROP experience to be part of Hand to Hold as a peer mentor for our new families.
It is important with new promising ROP treatments to understand ROP's biphasic pathogenesis to ensure that one is applying the right treatment in the right phase of ROP. Phase 1 ROP, or vaso-obliteration, occurs shortly after birth when the baby is exposed to a higher oxygen in room air or supplemental oxygen than in the womb. High oxygen decreases growth factors like vascular endothelial growth factor, or VEGF, needed for blood vessel growth, and this can destroy existing vessels and delay new vessel growth. So treatments in phase 1 should seek to increase VEGF secretion, and this can simply include limiting excess oxygen use in the first 4 weeks of life. Phase 2 ROP, or vasoproliferation, occurs about 4 to 6 weeks after birth because there are now not enough blood vessels to nourish the eye, and that leads to low oxygen or hypoxia and bleeding in the eye. Treatments for phase 2 should involve allowing higher oxygen saturations to provide adequate blood supply to the retina, and applying drugs that inhibit VEGF, such as anti-VEGF intravitreal injections, beta blockers like propranolol, caffeine given for apnea of prematurity, and vitamin A. We are grateful to have several anti-VEGF therapies in clinical use, but most of them do block more than one type of VEGF and can cause side effects, since VEGF is needed for vessel growth in other developing organs like the brain and lungs. This brings us to nanotechnology, which uses the smallest biomaterials to improve drug delivery to the eye while limiting systemic toxicity. Other promising research includes stem cells from the bone marrows, which can self-generate and differentiate into other cell types in the retina, and gene therapy, which can transfer or edit genes at a DNA level, and this can have long-term effects. So I hope for more rigorous laboratory testing for these therapies so we can find optimal doses to minimize toxicity, and also do randomized clinical trials to ensure that they're safe and have good efficacy before using it in our fragile preterm infants. Most of the emerging technologies for identifying ROP and its progression include digital retinal cameras, optical coherence tomography, or OCT, and artificial intelligence, AI. And they have sort of evolved over time to meet a specific need in improving either accuracy and efficiency of our clinical diagnosis and treatment. We all know that with advances in neonatal and perinatal care, this has led to an increased survival of very extremely premature infants, and that makes ROP still the leading cause of preventable childhood blindness worldwide. This has also placed an increased burden of ROP screening on the limited number of ophthalmologists, especially in resource-limited areas. And dilated eye exams can be quite stressful for this critically ill infants. So diagnosing ROP by stagings and zones is quite subjective, as we know. And this can vary between observers and can be a challenge when used clinically and in research. So digital retinal cameras have been really helpful, especially in remote, low, and middle-income countries, and can be a part of the medical record for education of families and staff. It also could be a challenge getting good quality images because of user expertise. Artificial intelligence has also been applied in ROP using machine learning and deep learning algorithms that can teach the computer to automatically recognize patterns and categorize these features as normal retina versus retinas with ROP. AI can also be optimized to incorporate clinical and human input. We're hoping as the technology evolves. OCT, or spectral domain optical coherence tomography, or SDOCT, is not quite yet mainstream ROP imaging tool, but it is non-invasive, it's portable, and it does give us a three-dimensional reconstruction of the entire retinal structure. And that can help diagnose very poorly detected retinal features, such as intraretinal neovascularization in mild ROP, or the extraretinal neovascular plaques in severe ROP and macular edema. OCT angiography can also look at blood flow in addition to OCT, and this is quite helpful in monitoring as well. So I'm really excited about these emerging technologies, and they hold great promise for the future of ROP diagnosis and monitoring. In terms of research on ways to prevent ROP, I believe that the first step is identifying significant risk factors. Prematurity is truly hard to avoid because the mother or baby's health could be at risk. Oxygen is the most modifiable risk factor for ROP, and excess of it can cause what we call neonatal diseases of oxidative stress, which include bronchopulmonary dysplasia, or BPD, in the lungs, intraventricular hemorrhage in the brain, and necrotizing enterocolitis, inflammation in the gut. So these organs all develop simultaneously in the low oxygen environment in the womb, and preterm birth into high oxygen disrupts their development and blood supply. So I love to advocate for a more integrated approach to clinical care, which is simply an awareness that all body systems are connected, and how we care for our lungs affects the baby's eyes, brains, and kidneys. I want to thank everyone for really bringing great and new perspectives to the understanding of the journey of ROP for our families in the NICU, as well as for the providers caring for these babies. I think the resounding theme here for everyone has really been that everyone is part of a team in the NICU. So I also want to encourage parents, and some of them are here, to believe that you are truly part of the team and that you are your baby's best advocate. And as you get to know your babies, it can be daunting initially for especially first-time NICU parents. They don't know what's going on. They're beeping everywhere. But with time, they do get to know the babies, and we do rely on them for that important information about how their baby feels or looks that day. So I want to also encourage providers to build trust with your parents. That is so important. Remind these parents to self-care, because there's a lot going on in their lives outside the NICU, and it takes so much courage for them to be there every single day. And each time they hear news, it's important to deliver that news gently and with some hope, no matter how dire it seems. That is what they're holding on to, that's getting them through the day, because the NICU can be a roller coaster. So I'm really just so proud to be part of this, and thank you for having me.